Most students get abdominal pain questions wrong, not because they don't know enough diagnoses, but because they don't structure their thinking early. They hear abdominal pain and suddenly think everything: appendicitis, pancreatitis, ulcers, labs. But that's not how experienced clinicians think. Instead, they use a simple, organized framework to narrow everything quickly. And that's exactly the framework we use here at ScrubNotes. We basically approach every chief complaint the same way. First, rule out anything dangerous. Then, follow clues from time and location. And finally, look for key diagnostic patterns. If you do this well, abdominal pain goes from overwhelming to something you can narrow down quickly. I'll walk through a case of abdominal pain and show you how this framework makes your process so much easier. And then later in the video, I'll show you the single diagnostic fork that dramatically reduces your differential list. Let's dive in. Here's the ScrubNotes framework. First, we generate a broad differential list. Second, we use focus history questions to guide our process. Third, we use targeted exams based on the information we gather in the history. And then we use what we've gathered from the exams and history to update our DDX list to come up with our working diagnosis and top 2 differentials. And then we present our findings. Okay, let's see how we can apply this clinical reasoning framework to a 42-year-old female who presents with abdominal pain. First, we want to build a broad differential list. And abdominal pain has one of the largest differentials in medicine, but most causes fall into a few major categories: hepatobiliary, gastrointestinal, cardiopulmonary, genitourinary, and gynecologic. So at this stage in the process, we're not trying to find the correct diagnosis. We're trying to be complete. This list alone doesn't get you there, so what matters is how you narrow it. That's where our focused history questions come in next. This second step in our framework is where we really start to narrow our diagnosis list. So instead of ordering labs, we want to start here first. To begin, let's clarify what they mean by abdominal pain. Where is it located? In this situation, it might be right upper quadrant. Can they describe the character of their pain? Is it sharp and colicky? That might indicate biliary. Does it radiate to the right shoulder or the back? That's pretty classic for gallbladder. Next, we want to inquire about the time course. Is it acute, like hours to days? That's pretty classic for biliary and inflammatory. Or do they have more recurrent episodes, which would be more similar to gallstones? Third, we want to ask about pattern clues. Does their pain get worse after fatty meals? That's associated with gallbladder. Do they have nausea or vomiting? That could be more GI related. And if there's a fever, that's indicative of an infection. Next, we want to ask about what they've eaten. Maybe they get this pain with fatty foods or from eating egg salad that sat out too long. Any medications that they take, because this could be drug related. And then, of course, we want to ask about any concerning red flag symptoms. So the combo of fever and jaundice is often associated with cholangitis. Hypotension could indicate sepsis, and persistent severe pain could be a surgical need. Now, let's put all this together. I've created an algorithm for how I like to approach right upper quadrant abdominal pain. So first, we want to check if there are any red flags. If we see any kind of hemodynamic instability, fever, jaundice, peritonitis, severe and persistent pain, or altered mental status, that's a good indication we need to do an ED or urgent evaluation. Let's say that's not the case for our patient. Remember earlier when I said I'd give you one key step to help you narrow your differentials? Well, this is it. We're going to use location and pattern to help us narrow down our list. So if we look at location, we've identified right upper quadrant pain. So we're going to focus on hepatobiliary questions. So we're going to ask about the time course. Is it acute, lasting hours to days? That's probably an inflammatory or obstructive cause. If it's more recurrent and episodic, that's more likely to be gallstones. Next, we want to inquire about the pattern and the triggers. So as I mentioned earlier, any fatty meals, pretty classic for cholelithiasis. Next, we want to ask about the pain pattern. Is it intermittent or colicky? Pretty classic for gallstones. Or is the pain constant or worsening? That's more likely to indicate cholecystitis. Next, we want to ask about any symptom signs, such as fever, because that's more likely to be associated with cholecystitis. If there's fever and jaundice, cholangitis is more common. And last, if there's no pattern, then we probably want to revisit our diagnoses list. We might want to consider PUD, pancreatitis, even pneumonia. any kind of a renal stone or infection. So instead of memorizing long lists of differentials, here's your key shift. You want to recognize patterns. For example, right upper quadrant pain after fatty meals is indicative of a gallbladder issue. So I think it's pretty common to divide the abdomen up into quadrants or these 9 areas because pattern recognition is one of our key approaches to abdominal pain. So within each quadrant, I'd want to ask about inflammation, if there's any obstructive issues, vascular, any kind of referred pain, or extra-abdominal symptoms. So today, for our patient, we're focusing on the right upper quadrant area, and that's what our algorithm and focus history questions we're targeting. Now that we've asked focus history questions and applied our algorithm, we can present our case. So we have a 42-year-old female who presents with acute right upper quadrant abdominal pain that began 6 hours ago after eating a fatty meal. The pain is constant, radiates to the right shoulder, and is associated with nausea and vomiting. She reports subjective fever but denies chest pain or urinary symptoms, and she hasn't had any recent travel or medication changes. Now that we've asked focus history questions, we can perform targeted exams instead of random exams or trying to do everything all at once. In an OSCE situation, don't forget to take vitals, make general observations. But let's walk through this table here with our top working diagnoses. So for cholelithiasis, definitely want to do an abdominal exam. We want to look at Murphy sign, right upper quadrant tenderness as well. So for our patient, let's assume there was some mild right upper quadrant tender to palpation, and there was no guarding. Next, let's look at cholecystitis. Again, we definitely want to do an abdominal exam, and in this situation, we want to test for Murphy sign. So for our patient today, let's assume the Murphy sign was positive, and as I noted before, positive for right upper quadrant tenderness. Next, let's look at cholangitis. We want to make general observations, check for any scleral icterus, and then of course perform an abdominal exam. Let's assume our patient doesn't have any jaundice and no systemic toxicity. Next on our list could be pancreatitis. So again, that abdominal exam is going to be our go-to here. But we want to see if we can recreate any of that pain or radiating to the back. So for our patient, let's assume there was no epigastric tenderness and no radiating pain. Lastly, we have peptic ulcer disease on our differential list. So again, abdominal exam here. And for our patient, let's assume that there was no epigastric tenderness. So now we're at step 4 in our framework, and we want to refine our DDX based on all the information we've gathered. We're probably not adding more diagnoses, but we're prioritizing. So for this patient, I'm leaning toward cholecystitis as my working diagnosis, but I want to still keep open the possibility of cholelithiasis and less likely cholangitis, given there wasn't any signs of jaundice or instability. Okay, we finally reached the 5th step in our framework, and we're ready to present our assessment. So we have a 42-year-old female who presents with acute right upper quadrant pain following a fatty meal associated with nausea, vomiting, and subjective fever. In-office exams today are notable for right upper quadrant tenderness and a positive Murphy sign. The acute time course, localizing right upper quadrant pain, and associated symptoms are most consistent with acute cholecystitis. Alternative diagnoses such as cholelithiasis and cholangitis are less likely given the persistent pain and absence of jaundice or systemic instability. Given this presentation, further evaluation with ultrasound is indicated. Before we summarize and wrap up, I wanted to give you 3 common traps that students make and how to avoid them. The first is jumping to labs too early. To fix this, you want to start with location and time course. So remember that algorithm we went through for right upper quadrant pain. And labs confirm your diagnoses, they don't replace it. Number 2 is ignoring the pain pattern. So forgetting to ask about triggers like fatty meals. Be sure to always ask about the pain and any recent foods they've had so you can help use patterns to narrow your diagnoses. Number 3 is missing those red flag symptoms. So be sure you always screen for any dangerous causes first, and you assess for fever, jaundice, instability, and so forth. Remember, fever and jaundice warrants urgent evaluation. If you take one thing away from today's video, it's that abdominal pain isn't about memorizing a long list. It's about checking for red flags and then asking targeted first questions, such as where is the pain and what pattern does it fit? So for our case today, we had the pattern of acute right upper quadrant pain after a fatty meal, pretty classic for gallbladder issues. If you want to get faster at clinical reasoning, not just for abdominal pain, I break down the same 5-step framework across the entire ScrubNotes Chief Complaint Series. Thanks for watching, and I hope you join me in the next one.